In episode 93 of Dermatology Weekly, a conversation about pediatric procedures in dermatology. This is Dermatology Weekly, the official podcast of MDedge Dermatology and Cutest Peer-to-Peer. Coming up on the news portion of Derm Weekly, the CDC cuts the COVID-19 quarantine time and impressive results with neoadjuvant T-VEC in advanced melanoma. And later in Peer-to-Peer, Dr. Vincent DeLeo welcomes Dr. Craig Burkhart to talk about dermatologic procedures in children, such as laser treatment of birthmarks or excisional mole removal. Dr. Burkhart is in the Department of Dermatology at the University of North Carolina and is also with the Burkhart Pediatric and Adolescent Dermatology in North Carolina. And now, the news. Our top story today, the International Psoriasis Council is suggesting an end to the categorization of the disease as mild, moderate, and severe. Speaking at the Medscape Live annual Las Vegas Dermatology Seminar, Dr. Bruce Strober said that these categorizations are vague and that they're defined differently by various organizations all over the world. Dr. Strober is a dermatologist at Yale. He said that what he and his colleagues on the IPC came up with is a very sensible approach to defining whether patients should get either topical or systemic therapy. In fact, there are only two groups of patients in psoriasis, those who should get topicals alone and those who should get systemic therapy. It's topicals or systemics. Under this IPC classification, psoriasis patients are candidates for systemic therapy if they meet at least one of three criteria. Those are body surface area involvement greater than 10%, disease involving the previously mentioned areas, or failure of topical therapy. He said that this approach is about treating patients practically, and that if patients meet just one of the aforementioned criteria, then they can move on to our current toolbox of systemic therapies, be they older systemic treatments, apremilast, phototherapy, or one of the 11 biologics currently approved for the treatment of psoriasis. Dr. Strober went on to say that the key point is for patients with moderate to severe disease, treatment should be based on individual patient characteristics. European dermatologists often use the Psoriasis Area and Severity Index, PASI, to characterize disease severity and monitor response to therapy. In contrast, American dermatologists generally find PASI too complex and time-consuming for use in clinical practice, relying instead on the amount of body surface area involved with psoriasis. Neither of these measures incorporates disease involvement in special areas, which, when present, ought to automatically place a patient in the systemic therapy-appropriate category. And neoadjuvant therapy with T-VEC has durable efficacy in advanced melanoma. This is according to the results of a phase 2 trial reported at the Society for Immunotherapy of Cancer's 35th anniversary annual meeting. The multicenter trial enrolled 150 patients with resectable stage 3B, 4, M1A melanoma who had at least one injectable lesion, thereby including many patients with in-transit metastasis. In the study, researchers randomly assigned patients to receive 6 doses over 12 weeks of intralesional T-VEC followed by surgical resection, or to receive the conventional approach of immediate surgical resection. The median follow-up was just over 41 months. The primary endpoint was 3-year recurrence-free survival. The researchers reported that the 3-year rate of recurrence-free survival was 46.5% with T-VEC plus surgery and 31% with immediate surgery. The median duration of recurrence-free survival was 27.5 months for the treatment arm and 5 months for the control. These results were comparable to results seen in 2 years, which were published in 2019 in the Annals of Oncology. The 2-year rate of recurrence-free survival was 50.5% with T-VEC and 31% with immediate surgery. Findings for both outcomes were similar when analyses were repeated after removing events that occurred after receipt of therapy in the adjuvant or metastatic setting. The 3-year rate of overall survival was 83.2% with T-VEC plus surgery and 71.6% with immediate surgery. In all, 50.7% of patients in the T-VEC group received subsequent anti-cancer therapy compared with 76% in the immediate surgery group. No new safety signals emerged during the additional year of follow-up. The trial's final analysis will be conducted after 5 years of follow-up. And finally today, the CDC shortens the COVID-19 quarantine time. The Centers for Disease Control and Prevention announced two shorter quarantine options, 10 days or 7 days for people exposed to COVID-19. Citing new evidence and acceptable risk of transmission, the agency hopes reducing the 14-day quarantine will increase overall compliance and improve public health and economic constraints. The agency also recommended people postpone travel during the upcoming winter holidays and stay home because of the pandemic. These shorter quarantine options do not replace initial CDC guidance. The CDC continues to recommend quarantine for 14 days as the best way to reduce risk for spreading COVID-19. People can now quarantine for 10 days without a COVID-19 test if they have no symptoms. Alternatively, a quarantine can end after 7 days for someone who receives a negative test and no symptoms. The agency recommends a PCR test or an antigen assay within 48 hours before the end of a quarantine. The agency also suggests people still monitor symptoms for the full 14 days. Reducing the length of quarantine may make it easier for people to take this critical public health action by reducing the economic hardship associated with a longer period, especially if they can't work during that time. Modeling by the CDC and academic and public health partners led to the new quarantine recommendations. The residual risk is approximately 1% with an upper limit of 10% when people quarantine for 10 days. A 7-day quarantine carries a residual risk of about 5% and an upper limit of about 12%. And that's it for this week in dermatology news. When we come back, peer-to-peer with Dr. Vincent DeLeo. And welcome back to Dermatology Weekly. It's now time for peer-to-peer.
Today we're talking to Dr. Craig Burkhart about pediatric procedural dermatology. Dr. Burkhart is from the University of North Carolina at Chapel Hill and Burkhart Pediatric and Adolescent Dermatology in Cary, North Carolina. Craig, thank you so much for joining us today.
Thank you, Dr. DeLeo.
So let's get started. Procedural interventions can have both positive and negative effects on the quality of life of pediatric patients, as you point out in your article. Can you share with our listeners about some of those effects?
Sure. So there's some things where it's obvious that a procedure by far and away has a positive effect for children. So if you have a bleeding pyogenic granuloma or a painful ingrown toenail, doing a procedure is almost always completely positive. In one visit, the problem is solved. And then there's the problems that we treat that are associated more with visual differences in children. Port wine stains or large congenital melanocytic nevi are two typical things I think about. And then the positives are, treating it usually helps the self-esteem, usually reduces stigmatization, and reduces marginalization within the community. So lots of positive effects. However, there's also some negative things you have to think about for children and teens. One is if it's an older child, they might have to adjust to an evolving appearance. So as their nevus goes away, there might be some scars that replace the area, and then they have to accept that as their new lesion. And some children, especially with laser surgery, will have to go back to school with the marks on their face that they had the laser surgery, and that leads to further questions from other schoolmates and maybe even a different kind of a stigmatization. And then another thing would be some people just become addicted to trying to find the perfect result, like complete resolution of a red spot on the face, and they just don't know when to stop. And hopefully their physician can help them know when to stop, so they don't have that kind of anxiety. And lastly, some kids resent that their parents think that there's something that might be wrong with them. So yeah, you have to be sensitive to how the child or teenager thinks about their lesion, and also the parents. And actually one more further thing is there's some new research studies in the congenital nevus arena, where some teenagers have had this surgery to remove their moles early in life, but then when these researchers asked them about the process, some of these teenagers wish that their parents had waited and just enough time for them to be part of the discussion about whether to remove it and whether they would rather have a scar or if that mole is part of them and they didn't want to have it removed. So it's a mixture.
Yeah, and actually that last comment you made leads to something else that you discussed in more detail in your article, and that's the ethical considerations that the dermatologists working on kids as compared to adults, that there are other ethical issues. Can you delve a little more deeply into that?
Yeah, so with adults, it's you get your informed consent. It's you and the patient, it's a two-party conversation. But with kids, especially older ones, teenagers in particular, there's a third person that needs to consent or assent to the procedure. And if all three people don't agree that this is the best thing for the patient, that's going to lead to an ethical dilemma where you're going to have to find out where the conflict is and what the best solution is for that child. And sometimes it's really hard to get that answer. What's the best thing to do? And you can always consult another colleague to get their opinion as well. Especially if you feel like you're in the corner and forced to do a procedure, it's always good to get a second opinion from another colleague in those cases.
I can see that can be difficult sometimes. We've talked generally about procedural pediatric dermatology. Can you go into some of the more common conditions that you and your practice and other pediatric surgeons get into? Give us some idea about those.
Cool. Yeah, I'd say the most common things would be vascular lesions, birthmarks, cysts, and hemangiomas. Those are the common things. So lots of things where you might need imaging beforehand. So some people might have like a cyst in the midline, and the pediatric dermatologist might be consulted to decide whether imaging is required before you do any surgical intervention there. With hemangiomas, it's kind of a mixture of medical and surgical treatment at the same time. So we definitely help out with deciding when medicine is appropriate, when surgery is appropriate, or lasers. And then, of course, anything that requires sedation. And I'd say vascular lesions and birthmarks are the two main groups where you might consider sedation.
So you just briefly touched on treating things with lasers. Can you talk about the ones that occur primarily in the pediatric age group?
Yeah, I would say by far the most common laser that we use in pediatric dermatology is the pulse dye laser. So there's tons of red spots that respond really well to the pulse dye laser. It's also something that works fast. So you can tailor it to children who are awake where you need to do a quick procedure, or you can bring it to the OR and use higher energies in that situation. I think more and more pediatric dermatologists are starting to use ablative lasers. So there's lots of lumps and bumps basically that can be removed with either a CO2 or erbium YAG laser. So those would be the workhorses: pulse dye laser and ablative lasers. I kind of feel like right now there's a movement towards treating more hidradenitis patients with various hair reduction lasers. So I think I'm seeing a lot more of my colleagues using the alexandrite or Nd:YAG for those people.
And moving from lasers to just general excisions, what kinds of things should we be thinking about?
Yeah, so a common situation for excisions is a lesion on the face or scalp of a child, and people really want to know about the best timing to consider removing that one. So during my fellowship, we had a rule of thumb. So if there's a lesion on the central face that's a ½ centimeter or larger in diameter, it might be a good idea to consider removing it before age of 2. If you have a lesion that's 1 centimeter on the lateral face or 1.5 centimeters on the scalp, those are times to consider possibly doing an earlier excision. And I would say the other thing to consider about excisions is a lot of kids after age 6 are able to tolerate procedures awake with without needing general anesthesia, and your interaction with them can be reliable enough to predict who can tolerate a procedure awake versus who can do a procedure asleep. So with a typical 6-year-old that might have a lesion on the arm, you can ask how they do at their pediatric appointments with their vaccinations. And if they're a child that sits for the vaccination without a problem, they're definitely ready to have minor surgeries awake. If they're a child that's 6 years old and you have to pull them out from behind the bed, they're definitely a child that is not ready to have surgeries done awake. But you can do little things like that to find out if they're ready.
You know, this is truly an incredible article that you put together, and it's actually all of the things that you approach in the article can't be approached in a podcast. So I certainly recommend that all of our listeners go to your article if they're seeing kids and if they're doing surgery on kids. So just a big closing general recommendation for the practitioner out there for approaching surgery in children?
I would say my favorite recommendation would be anything you can do to help children avoid general anesthesia is always appreciated by families. And then it's going to vary based on lasers. You might want to approach things earlier. Or if you're doing excisions, you might want to wait later till age 6 to evaluate children. But I think as dermatologists, we are really good at doing outpatient procedures without general anesthesia, and I would utilize our skills.
Thank you very, very much. This has been a really interesting discussion. Any other last words?
That's right. I think pediatric dermatology, the procedural component is going to grow over the next 5 years. 11 years ago when I started, there were just a few of us doing it. And now it seems most people graduating are very interested in it and doing some neat things with a lot of different lasers, a lot of different new techniques. It's an exciting field.
So, Craig, thanks so much for joining us today. And I hope we can all stay safe and sane through the rest of this epidemic. And have a good day.
Thank you, Dr. DeLeo.
And that's a wrap on this episode of Dermatology Weekly. Derm Weekly is produced by MDedge editors Elizabeth Meshkati and Melissa Sears. The peer-to-peer portion of the show this week was hosted by Dr. Vincent DeLeo. All of our podcasts are produced by our executive editor, Kathy Skarback.